I think we will start with questions from the audience. Anyone has questions to our presenters?
Any more questions? Karen?
Great talks by all of you. Really impressive discussions here. I have a question for Dr. Ramsey. Clearly, doing a redo pouch is feasible. But in some of your publications, correct me if I'm wrong, seepage and leakage rates after a redo pouch are on the order of 60–70% in the daytime and nighttime. And you mentioned that you would offer this in select patients. What kind of a discussion do you have with these patients before you offer them a redo? What are you telling them to expect post-operatively with respect to bowel function and then also sexual function?
Okay, sure. So I think it's a very fair point. What I tell them is this, as what I said as a first line, is that if you can live with the ileostomy, move on, run away from me. That's really the honest, the first remark that I make. And that's one of the reasons I really stage them with the initial ileostomy, have the patient to have that 6 months and to decide, neither for an excision nor for a redo, for them to absorb that this is something palatable. The functional outcomes of the redo pouches is not the greatest for a normal, functional person. But what the trade-off that I tell them, and this is the patient's story, not my story, you need to put the things to perspective. You're going to come and tell me I have this problem, that problem. When I tell them, okay, do you want to have the ileostomy back again? The answer is, look at me, are you crazy? What are you talking about? So that's really the quick perspective that I can just say. You're absolutely right. They're not going to get a great function. For the redo pouches that I significantly tell them about the infertility rates, I try to do same thing what Dr. Ashburn talked about, pexing the ovaries. For male population, I tell them a little bit increased risk of a sexual dysfunction. I actually have them to bank the sperm before the redo pouch because of that concern that they need to know about it. Full transparency, as what you articulated, is very important.
Thank you very much. Any more questions from the audience?
Scott.
Hi, just great talks by everybody. I'm one of the lone pediatric surgeons that are here. I've inherited probably 3 or 4 patients who really had who have very long rectal cuffs that were done by one of the other surgeons in the community. And in general, they've all been, from a pouch standpoint, been behaving well, but a couple of them have had recurring cuffitis or inflammation in that remnant rectum that are being treated topically. When do you guys decide to go back and do a pouch revision or excise that remnant, or when is it better to continue medications if they're controlled?
I'll take it, because that gets into what Feza was talking about there. And I'd ask you respectfully as a pediatric surgeon, I know that in my area there are 2 pediatric surgeons who for many years have been doing intentionally pouch rectal anastomoses. And I think I just did 3 weeks ago the 5th one. You're leaving, proctitis. So I don't think that it's ever okay, to do a pouch rectal generically anastomosis. And that would be a great example of somebody who's really never even had a chance, to have good function with pelvic pouch. So I think that, by definition, with ulcerative colitis, the disease is typically worse in the rectum. And, I personally had to do quite a number of those where taking pouch rectal anastomosis, and I'm not talking about a 2-centimeter cuff versus 1. I'm saying there's people out there who are doing anal pouch anastomoses to the rectum 15 centimeters from the anal verge, and I think that's respectfully a really bad operation.
I think I'm sorry if I could. One of the things I think this is a history repeating itself. When I was a really intern, with my mentor, there was a big argument between the Professor Nichols from UK side promoting the mucosectomy versus my mentor and Neil's mentors that he was promoting a stapled anastomosis, and Professor Nichols' point was absolutely in one way correct, because he was saying you're doing a shortcut with these staple techniques, you're leaving a long cuff. And our mentor's point was, look, you can do this right. You can get in and leave a 1 centimeter cuff, it's okay. Now we're living this again, and I'm not blaming the MIS. We're doing a shortcut, not realizing the fact that we're going really down that where we need to be. Now, can you go down laparoscopically or robotically? Absolutely. But it's going an evolving process, we're living it. So the patients that you're describing, unfortunately, anything that anything greater than 2.5 centimeters of a cuff after a failed medical therapy, nothing less than a surgical is going to work. Either they need a redo to be able to restaple from top, record this guy, probably it's going to, like a Messiah, I said this, a transanal TME can be a very good option in these patients, going down and removing that thing and bringing down with that new technique that's out there.
Scott, can I ask you a question? Because we see this also in terms of pediatric surgery. Is it acceptable? What do you guys teach in terms of pediatric surgery, in terms of the level of the distal anastomosis?
Yeah, I mean, these are, the patients is referring to ones that are inherited. I think the teaching has been, a 2 to 4 centimeter cuff. At least that was the teaching I had in my fellowship. I think one of the problems has been with kids, has been this, particularly in younger kids, people evert the rectum, and then you're basically hugging their bottom with your staplers. You fire it across. And I was talking with Dr. Van Almen about this earlier. I mean, I think in the younger, thinner kids, being able to fire that stapler right above the columns and having a short cuff is reasonable. I have personally found it to be very challenging when you have, the overweight, 14 or 15-year-old. And I think that may drive some of that length in having a cuff that's too long. I don't know.
So I agree with the comments that have been made already, and to directly answer your question, I think the decision of when to convert the ilioproctostomy to an ilioanal is driven by the patient's symptoms and the relative degree of medically refractoriness. I have a question for the panel regarding sexual infertility, actually. So, Jean, you mentioned staging for patients who desire to get pregnant. I'm curious if anyone's had any trouble with patients who have been endometriostomy who then get pregnant with peristomal issues, because I, in particular, I hate to refer to anecdotal medicine, but I've had one patient in my career who got pregnant and she had an incarcerated peristomal hernia during her second trimester, and it was a toad's wild ride, so to speak.
I think the one thing that you see a lot is prolapse. And it's particularly during or after pregnancy, but particularly during. And I think the challenge with a pregnant patient or somebody who desires pregnancy with a stoma is not really part of the pregnancy experience. And so you have young women who desire to get pregnant and they think they're having to get used to a stoma, just hard stop. And then now they're going to be pregnant with a stoma, which really ruins the pregnancy photos and the delivery experience and all this stuff. And now they have a prolapse stoma. So I think that this is really when you engage your enterostomal therapist. I think number one is have a great relationship with your enterostomal therapist and help them have a great relationship with the patient to get through these, because a lot of these stomal issues can be managed, and particularly when they're pregnant, less is more. Of course, we don't want to be operating on or doing anything invasive to pregnant women unless we have to. So I would say in large part these can be managed with a great enterostomal therapy. But prolapse also is going to be a problem.
I have a question to the panel and maybe to Dr. Lopez. In terms of, what could you comment in terms of success rates on weight reduction? So you have morbidly obese patient, you do subtotal. Probably all of us can handle this. Then what? We tell them, oh, go lose weight. What is the success rate? Even what you do, like with a surgery, without surgery? And is there any BMI of the patient you would tell them, you know what, that's it, we're not going to do J-pouch for you because this is bad?
I think the success rate without surgical intervention is very low. I think people can lose some weight, but generally not significant enough to make an impact on their ability to have a pouch. There, I would say, is not an exact number for a BMI that would fit for an absolute stomp at doing pouch surgery, but in the Mayo paper, their sort of number, their BMI that really showed an inflection point was the 34. Above 30 was sort of the point rate where the rate of completion would go down, but 34 was the average BMI of patients that could not have a pouch completed. That said, they excluded 20 of their patients that didn't have a pouch, so that were obese and didn't get included in patients that got offered a pouch. So probably those numbers are even a little skewed.
There's several comments I might make in that context. The first is that a lot of these patients, after they get their total colectomy, deserve some weight gain because they're pretty sick and they get their 20 or 30 pounds. The second point is that when you see them at that 4, 5, 6 month point in anticipation of stoma creation, stoma reversal and the pouch creation, if they are really getting big, as opposed to many other patient groups who typically will not lose your weight, you can basically say, I'm not closing that stoma until you lose some weight. And they are very motivated. They will lose weight, and I've had fair success in that regard. But then there's another whole group of patients who are truly morbidly obese, the BMIs of 38, 90, 40, 45. Those patients aren't going to lose a lot of weight in the context of your surgery, and you're going to be waiting a long time. And that's where I basically, I do the modified 2 procedure, and it's very successful.
Over 30%, over 30 BMI, I recommend them the bariatric surgery at least to see them before consider getting the J-pouch. Sometimes in massively obese patients, which I have one coming on the way, with a colitis, with a 20 years of steroid dependency, those patients sometimes they just get an ileostomy, don't even do the colectomy, and then do the bariatric surgery and then come down there. But I think it's a great question.
Yeah, the abdominal colectomy, especially hand-assisted, you can do it to anybody. I mean, it's as long as the abdominal wall is not thicker than my arm, I guess you can do it. The anecdotal medicine is also the fact that the mesentery of the small bowel, after you have a stoma for a while, sort of lengthens or stretches and helps you reach longer. And I've sent patients for a gastric sleeve. I wouldn't say routinely, but anything above 40, and you don't lose weight, you go to see the bariatric surgeons.
Many people feel that a robotic approach for the morbid obesity pelvis may be helpful as well. I had a question for Walter and for the panel. Anyone have any experience with homemade endosponges? I think Feza does. Yeah. Anyone else?
Yeah, I'll just tell you that's what I referred to. I've done one. The mistake I did in that context was that I did not grasp the endosponge itself in order to remove it from the cavity. I pulled on the catheter, which had simply been tied down with a couple of sutures, and it just slipped right out, left the sponge behind. 30 minutes later with scopes and Lone Star retractors and all that stuff, we finally got the sponge out. So I'd simply say that, the technical aspects of building your own endosponge are significant in the context of what you want to be a quick, slick placement and removal. And if that doesn't go well, then you're in the OR looking through a tiny little anus, stretching it, trying to get after the retained foreign body that you have to remove.
The other option from New York, there is a direct flight to Amsterdam. Yeah.
So we do have 2 cases, and one of my, the research fellows who went to overseas to Turkey, when I was visiting there, he showed me and sent a video. So we applied that NYU, used like a regular sponge, and then we used the tubing, we suture it, and we have actually video submitted to one of the meetings as a video, as a reference to do that. Out of those patients, one of them getting closed next month, so we were able to accelerate the healing to 4 months rather than a year. And the other one, we just finished that thing. Hopefully we'll be able to close it in 2 or 3 months. But we haven't closed them primarily after we pulled it out. We still left it for a secondary healing, which I think there's a room for an opportunity.
I think Dr. Bemmelin could speak to this, but after reading the fine print in some of these studies, there were a few tricks that I'd missed. One of them was irrigating through the catheter before you remove it, with peroxide, for example, to loosen it a little bit. The other one is that if you're going to hook it up to a conventional vac drainage system, which we all know for abdominal wounds, that's high vacuum type stuff. I do not know what the actual vacuum negative pressure is on what they term this low pressure suction container, but they term it a low vac container. Do you know, Dr. Benwolman, what the pressure is on that, or the suction pressure, the reverse pressure?
On the Roderon bottles, which comes with the sponge, that's 150 millimeter mercury.
It's about 50?
150.
15? 1.5 or 5.0?
150.
Yeah.
And if you use it in the esophagus, they use 80 mercury negative pressure, but then on an active pump. And some say, I don't have experience with that it's not bad to have even higher negative pressures. It increased the cleaning and the granulation tissue even more. But
did you grab any small bowel into that? I mean, that was our concern in our patients.
Well, you never should push a sponge too high up, because there are some anecdotal reports that there was small bowel behind the leaking anastomosis, and that there became a fistula. So I've had occasions that I exchanged the sponge after a laparoscopic procedure, and that in the endoscopy room that I entered with the scope, the abdominal cavity, pushing up the small bowel.
Do you always use that over-tube push technique to place these?
I think it's very important to use the over-tube, because then you preserve a relatively small hole.
Yeah.
If you do it surgically with a clamp, then you damage the remaining anastomosis, making the defect bigger, and particularly the distraction between the two sides will be bigger.
Right.
I
think the technical details here matter in this kind of the success.
It's extremely important that the distance between the neorectum and the anus remains very short. Otherwise, you're never able to close it.
We have a question from the audience, whether is it possible to remove the pouch and make the other pouch in the future? Means I assume they're talking about very low Hartmann's closure. Whether is it feasible or possible, and we'll have our experts to comment, to go back in any situation in the future.
I'm not sure why you would do that.
Okay, can I take that? Yeah. So 4 patients, 3 of them worked. 1 patient is waiting, that just did it 2 months ago, major pelvic sepsis, mesentery was scarred down. She's very keen for reconnection. I couldn't get it reach. So retreat, I always tell the residents of fellow, is a sign of maturity. But what I did is, again, you need to get this done in a year. I put a bunch of Penroses through the anus to the pelvis with Ceprafilm wrap. So the critical thing that is to avoid the bladder and the uterus not to go down, to be able to find that hole. So, but you cannot leave an open hole for a decade either, otherwise they get a nightmare presacral sinus. So hopefully in a year, the mesentery is going to elongate and everything to do that. But with this technique, we were able to get 4 out of 3 and the 5th on the way. So the answer is yes, but you got to be really pushing the limit in that one.
I just did that. I just did that, and I think that you have to expect the worst.
What's that?
I think you have to expect the worst in those situations. This was actually a pouch not taken out for sepsis, but the pelvis is completely obliterated in some cases, and I think you have to expect that it's just going to be closed up, and there's not going to be any anatomic planes and ureteral stents and lighted pelvic retractors and things like that, and also the patient going to sleep understanding that that might not be feasible. I think that that's even more important in that situation than even in a quote-unquote straightforward redo pouch.
Willem?
I have 2 questions. One is with respect to the dyspareunia, which is reported in women. Don't you think it's caused by the fear of women leaking stool during having sex?
Say that again?
We're having a tough time with echo to understand.
Sure, yeah, I had this.
Without the microphone, maybe?
Yeah, maybe without the microphone.
We talked about dyspareunia in women, and it's concordant with, let's say, erection difficulties in men. So we don't see much difficulties in men after bowel surgery, but we do see 40% dyspareunia caused by the fact that women are afraid of losing stool during having sex. So they're exactly
Well, I guess I'll take that one.
I always counsel my patients, together with the doctor, that might be interfering with good sex life.
I think there's probably a lot of issues. I think that's a big one. I would hope that men would be concerned about that as well, but maybe not. But I think men are from Mars, women are from Venus. Like I think, sexual function is completely different for men and women. And I think it's hard to predict why in men sometimes they aren't so impaired, in women they are. But also there was a thought that some of the adhesive disease around the vagina can cause pain. And I think certainly that would contribute as well. But I think fecal incontinence during sexual intercourse would be bothersome. I would assume that would be for everything, but I think that's a big problem. I think most women would say, yes, I would be concerned about that.
I advise them to empty the pouch before having sex.
I think that's a great idea.
I'd like to ask a question, if I could, because we have so many strong experts here. What about the issue of using seprafilm in the vicinity of the fallopian tubes, the ovaries, the pouch, et cetera, and trying to preserve fertility? Does anybody do that? I know the literature is a little sparse.
My fellow asked me this a couple of days ago, and as we're all aware, the original seprafilm data suggested if you wrap the anastomosis with seprafilm, that the anastomotic leak rate actually increases. So, as Jean mentioned, my approach is to try to do the pouch laparoscopically if I can, and I also have a relatively low threshold for ovarian apexy, as Jean mentioned, for patients who would like to maximize their fertility in the future.
But does anybody use seprafilm? Does anybody use seprafilm?
Fez's study just briefly showed
Open surgery.
that there was no difference.
So no one uses
I'll use it in open surgery if I have to do it open.
Do you use it, Phil?
Give it open surgery.
Willem, I wanted to comment on your question. So I think an obvious anatomic difference when we make pouches for men and women is that we tend to mobilize into the rectovaginal septum quite a bit. And I think there's this anatomic issue there as well that may be different between the genders.
So the other issue is that my fear of doing a pouch excision is that they will have a chronic calcium sinus. Instead of they having discharge from the pouch, they have a chronic abscess which is leaking through the perineal wound.
Great question.
So that's one thing. So what does the panel do to prevent that? Do they put momentum or other tissue in the cavity to prevent that? And my second question is, have anyone experienced about sexual function is after pouch excision? Because all the pelvic organs, they will displace if you don't fill up the cavity. They will displace posteriorly, both the prostate as well as the bladder and the vagina, causing sexual problems and urinary voiding problems.
So I think the second question, no one really knows the answer. Yeah, to my knowledge, nobody's actually studied sexual function, comparing, diversion versus pouch excision. With your first one, you're absolutely right, and that was what I was trying to highlight, is that especially, I think if you have, like, say, a pouch that for whatever reason doesn't have pelvic sepsis but it's not working, anal transition zone neoplasia, I think it's like any other proctocolectomy with ileostomy, you know what I mean, that you're at low risk for that. But there's no question in someone with a water can perineum who has card-carrying, Crohn's disease of the pouch, you're right. That's not just that it can happen, it's likely to happen. And lastly, that I think in this day and age of laparoscopy, there aren't really very many patients walking around who still have their omentum, after they've been through that to use. But if it was there, I would certainly use it, I agree.
Because I have to deal with these problems, I always preserve the omentum.
Yeah.
Because
Yeah.
I know what big problem you have if it's not empty.
So I treat this fistulizing pouch problem like fistulizing perianal disease in Crohn's. And the way I do it, I leave the anal canal, take the pouch, and let the sepsis resolve and put cetons galore if I need to, and when everything is gone, then approach it at a second stage and do the completion perianal proctectomy. Doesn't eliminate that risk, but rather than do this major, create this major pelvic wound or perineal wound when there is active sepsis. So that it's sort of similar to what I would do in perianal Crohn's disease. Otherwise, I take the omentum, so there is not much else to do.
What I found helpful in the patient who did not have momentum anymore is to do a closed pouch excision, preserving the mesentery of the pouch, putting that in the pelvis.
Yeah.
What about if you have Crohn's disease? You leave the Crohn's mesentery.
Not in Crohn's disease. I don't dare to leave the mesentery.
But in regards to the transition towards more laparoscopic procedures, which is happening with my practice as well, when I used to do open colectomies, I would take the omentum because the teaching was, and I agreed, that you'd had to then deal with a whole bunch of adhesions from the omentum. You took it at the time of total abdominal colectomy. When I'm doing total abdominal colectomy laparoscopically, I elevate the omentum, I leave it behind, and I specifically like leaving it behind because it then bolsters the pouch creation subsequently. So I think transitioning to the MIS preferred course of care, technically speaking, has facilitated preserving the omentum, and I think it's a good thing for these complications.
And I would just say I was surprised by the comment about leaving, the mesentery, if you will, of the pouch. Because if I'm doing a pouch excision, what's the pouch and what's the mesentery is largely a theoretical issue. So, I mean, hats off, I can't imagine trying to remove the pouch and leaving the mesentery in a patient with pelvic sepsis.
So, for show of hands, who preserves the omentum?
Laparoscopic.
Yeah, laparoscopic. Okay.
But I think there's just such a high rate of non-healing wound. No matter what, there's such a high rate of non-healing perineal wound, and I think some of the strategies of using a wound vac therapy, or I've had a lot of success with hyperbaric oxygen if you have that available. I almost use that more than anything, and sometimes it's hard to get access to or insurance to cover, at least in the U.S., but I find that to be very effective, at least to control the wound.
Yeah, I'd also rather put a gracilis flap in at the index pouch excision as opposed to dealing with a presacral sinus and having an interval operation for that. But that also is more for the fistulizing perineal Crohn's disease pouch patients.
Steph, can I ask Dr. Ashburn a question? I think for those of us who are, if you will, descendants of Dr. Fazio, do that oophorexic, thing, whereas whenever I mention it, everyone says, like, you do what? What's the data there? Because I've actually stopped doing it because I feel like I'm going to go to jail for putting stitches in the ovary in this day and age,
There's no data, and I really, I do it out of teaching, habit, like you said, and the more I read about IVF and how that might impair egg harvest with IVS, it did give me a lot of pause. Yeah. And I also, I made a video for this that I omitted, but when I was doing it, I thought the same things you were. There are so many opportunities during what would be a very simple technique that would take 2 seconds to do that you could actually cause more problems. Sometimes I've done it and I've thought, well, I feel like I'm kinking the fallopian tube doing it. Or what happens when I close the wound with the lateral pelvic tissues? Are they going to come in and kink the tissue? Should I just leave it and, maybe there's some scar formation and maybe not? I think that's a really, really important thing that I don't know.
So the ovarian, there is some newer data coming out, not in IBD, but in rectal cancer and other patients who require pelvic radiation, and there is a bit of a resurgence in the fertility community for doing ovarian transposition before radiation therapy. I think it's early, and it's very immature data, but there is a growing resurgence of this technique.
Yeah. I think that's a different issue, with the radiation, but I might suggest be helpful, in Cleveland if you looked at that, it wasn't to me, Jeannie, it just goes to show you how different, I didn't know that I was doing it for fertility reasons. I thought I was doing it so that I would tack the ovaries up so that it was a young woman that when she got to be an old lady, if she needed a new oophorectomy, they wouldn't have to remove the pouch to get to the ovary. And if she had a pelvic ultrasound, it would be easy to look at, so I didn't really know I was doing it for fertility reasons.
Well, I'll just say that there also is the phenomenon, I don't know how often you've bumped into it, but of those ovaries dropping down behind the pouch. You know, you put the pouch and so when I'm closing and I see those ovaries drop down into that retropouch space, I pull them up and I either close the peritoneum with a couple of stitches or I tack them up. But that's not because of fertility. That's simply to avoid that entrapped ovary behind the pouch, which is a described complication that can be quite problematic. You know, so I do it occasionally, but not for fertility issues. Okay.